Welcome to This Week in Physical Medicine and Rehabilitation. This week we are covering 10 notable papers spanning stroke rehabilitation optimization, cutting-edge strategies in spinal cord injury management, and evidence-based protocols for surgical and post-operative recovery. We will examine how system-level models, clinical prediction tools, and targeted pharmaceutical interventions are reshaping the physical medicine landscape. Let us dive in. We begin with a critical look at stroke rehabilitation, where clinicians and policymakers must balance high-quality recovery with financial constraints. A major study published in the Archives of Physical Medicine and Rehabilitation by Hayes and colleagues evaluated the cost-effectiveness of discharging stroke survivors to inpatient rehabilitation facilities versus skilled nursing facilities from a United States healthcare payer perspective. Historically, inpatient rehabilitation facilities have been perceived as more costly due to their high-intensity multidisciplinary therapy, but their long-term value has remained a point of debate. To address this, the researchers developed a decision analytic model, simulating 90-day outcomes for adults with either ischemic or hemorrhagic stroke who required institutional post-acute care. The model applied utilities for 4 distinct health states, comparing home versus long-term care and minor versus moderate disability, to estimate 90-day quality-adjusted life years. Looking at mortality, community discharge, readmission, and functional recovery, the study revealed that inpatient rehabilitation was actually the dominant strategy. It was associated with lower mean 90-day costs of $43,062, compared to $49,319 for skilled nursing facilities, representing an incremental savings of $6,257 per patient. Furthermore, inpatient rehabilitation yielded superior clinical effectiveness, producing 0.57 quality-adjusted life years compared to 0.37 for skilled nursing facilities. Secondary analyses using functional mobility metrics confirmed this dominance. Patients in inpatient rehabilitation facilities had a vastly higher probability of achieving clinically meaningful improvements in mobility and self-care. Specifically, 86% of inpatient rehabilitation patients achieved meaningful mobility gains on the AMPAC mobility scale, compared to only 30% of skilled nursing patients, while AMPAC self-care improvements were 91% versus 37%. Probabilistic sensitivity analysis proved the robustness of these findings, with inpatient rehabilitation remaining the cost-effective option in 81% of 10,000 simulations. This study provides robust economic and clinical ammunition for physiatrists, advocating for immediate inpatient rehabilitation facility placement over skilled nursing facilities, proving that higher upfront intensity ultimately reduces the overall financial and physical burden of stroke. While selecting the right facility is crucial, predicting when a patient will regain functional mobility like independent walking is equally vital for discharge planning. In the Journal of Rehabilitation Medicine, Kim and colleagues investigated how the admission work balance scale can be used to predict independent walking at discharge. In this multi-center retrospective cohort study involving 565 stroke patients across 3 inpatient rehabilitation centers in the Republic of Korea, the researchers sought to establish whether the Berg balance scale could act as an independent predictor after adjusting for major confounding variables. The cohort included 316 patients with ischemic stroke and 249 with hemorrhagic stroke. They discovered that the admission Berg balance scale was indeed a strong independent predictor of walking independence, with an adjusted odds ratio of 1.053. Interestingly, the discriminative ability of the Berg balance scale alone was statistically equivalent to a complex multivariable prediction model. However, the most clinically significant finding was that the optimal cutoff score differed dramatically by stroke subtype. While the overall cohort optimal cutoff was 24 points, the subtype-specific analysis revealed that patients with ischemic stroke required a score of 33 points to predict independent walking, whereas patients with hemorrhagic stroke required a cutoff of only 12 points. This difference suggests that clinicians should apply subtype-specific thresholds rather than a single blanket score when utilizing the Berg balance scale to guide prognosis and tailor precision rehabilitation plans for stroke survivors. Moving from inpatient rehabilitation to the outpatient management of milder cerebrovascular events, a study in clinical rehabilitation by Walton and colleagues investigated the effectiveness of integrated cardiovascular rehabilitation for individuals who experienced a transient ischemic attack or mild stroke. This randomized controlled trial enrolled 140 adults with a median age of 73 years who were randomized to either a once-weekly 6-week cardiovascular rehabilitation program or standard usual care. The investigators tracked outcomes at 6 weeks and 6 months, measuring functional exercise capacity via the 6-minute walk test, physical activity levels, body mass index, waist circumference, blood pressure, and quality of life scores. Ultimately, the trial demonstrated that the structured cardiovascular rehabilitation program was not more effective than usual care in improving physical exercise capacity, physical activity levels, anthropometrics, or blood pressure. However, the intervention did show short-term psychosocial benefits, with quality of life coping scores improving significantly in the rehabilitation group at 6 weeks. The authors suggest that future trials should investigate higher intervention dosages and evaluate transient ischemic attack and mild stroke populations separately, as the low frequency of once-weekly sessions in this trial may have been insufficient to drive physiological cardiovascular adaptation. For the practicing physiatrist, this highlights that while short-term exercise programs provide valuable psychosocial support, more intensive or prolonged regimens may be necessary to achieve objective physical and cardiovascular improvements in this population. Next, we transition to spinal cord injury management, where emerging technologies and novel pharmaceutical applications are challenging conventional treatment paradigms. In the Journal of Neuroengineering and Rehabilitation, Liu and colleagues conducted a comprehensive systematic review of transcutaneous spinal cord stimulation, a non-invasive neuromodulation technique that has gained attention for its potential to restore motor function. Synthesizing 25 studies representing 353 patients, including 9 randomized controlled trials, 10 non-randomized studies, and 6 case series, the authors evaluated the effects of transcutaneous stimulation on motor recovery and functional independence. Their qualitative synthesis revealed that while transcutaneous spinal cord stimulation may offer some beneficial effects for upper limb motor function, balance, and postural control, there were no consistent or stable improvements in lower limb motor function, walking ability, functional independence, spasticity, or quality of life. Furthermore, according to the grade assessment, the overall certainty of the evidence was very low, limited by small sample sizes, methodological weaknesses, and high heterogeneity across the literature. While the stimulation was safe and well tolerated with no serious adverse events, the clinical message is clear. Current evidence is insufficient to support its routine clinical efficacy, and high-quality randomized controlled trials are urgently needed before this technology can be widely recommended in standard clinical practice. While neuromodulation remains an area of ongoing research, managing neuropathic pain in patients with spinal cord injury remains an immediate daily clinical challenge. A novel retrospective study, published in the American Journal of Physical Medicine and Rehabilitation by Shields and colleagues, explored the potential of calcitonin gene-related peptide inhibitors to manage this refractory pain. Neuropathic pain after spinal cord injury is driven in part by hyperexcitable nociceptors and aberrant sprouting of calcitonin gene-related peptide fibers in the dorsal horn of the spinal cord. Using a large de-identified electronic medical record database, the researchers compared the odds of being prescribed a gabapentinoid, a standard first-line agent with a heavy side effect profile, within 30 days of initiating either a calcitonin gene-related peptide inhibitor, topiramate, or propranolol. The results were striking. Patients initiated on calcitonin gene-related peptide inhibitors had significantly lower odds of requiring a subsequent gabapentinoid prescription compared to those taking propranolol, with an absolute risk reduction of over 4% in a cohort of 3,527 patients, and compared to those taking topiramate, with an absolute risk reduction of over 7% in a cohort of 4,890 patients. No significant difference was found between the propranolol and topiramate groups. This suggests that targeting the calcitonin gene-related peptide pathway, originally approved for migraine prevention, may offer a novel, highly effective therapeutic avenue for spinal cord injury-induced neuropathic pain, potentially reducing the clinical reliance on gabapentinoids and their associated side effects like somnolence and cognitive clouding. In addition to pain and motor deficits, autonomic dysfunction is a hallmark of spinal cord injury that requires careful monitoring during rehabilitation. Writing in Disability and Rehabilitation, Van Oort and colleagues utilized the Dutch Spinal Cord Injury Database to examine resting blood pressure levels and clinically meaningful blood pressure changes in 1,286 patients admitted for inpatient rehabilitation. The cohort was predominantly male, with a mean age of 58 years, and the majority had a high-level injury at or above the 6th thoracic vertebra, with motor incomplete lesions. At admission, higher systolic and diastolic blood pressure levels were associated with a higher body mass index, a lower neurological lesion level, and motor incomplete injuries, while older age and antihypertensive medication use specifically correlated with higher admission systolic pressure. Interestingly, Although the overall cohort's mean blood pressure and heart rate did not change significantly between admission and discharge, the prevalence of both hypertension and hypotension decreased, indicating a stabilization of autonomic control over the course of rehabilitation. Older age and the use of general cardiovascular medications were associated with a clinically meaningful increase in systolic blood pressure during the stay, whereas the use of antihypertensive drugs was associated with a decrease. For clinicians, these findings underscore the high variability of blood pressure dynamics in the spinal cord injury population, emphasizing the need for individualized cardiovascular monitoring and medication titration during the transition through inpatient rehabilitation. We now turn our attention to orthopedic and surgical rehabilitation, where preoperative preparation and specialized post-operative protocols are showing significant utility in optimizing patient outcomes. In the archives of physical medicine and rehabilitation, Reef and colleagues investigated the impact of the Comprehensive Care for Joint Replacement Mandatory Bundled Payment Model on the delivery of preoperative physical therapy or prehabilitation for Medicare beneficiaries undergoing lower extremity joint replacement. Using claims data from over 62,000 patients across 945 hospitals in the United States, the researchers used a difference in differences analysis to compare hospitals in bundled payment treatment areas with those in control areas. They found that the implementation of the mandatory bundled payment model led to a significant 3.46 percentage point greater increase in the proportion of hospitals delivering prehabilitation in the treatment areas compared to controls. This demonstrates that shifting financial incentives toward episodic value encourages hospitals to proactively invest in preoperative rehabilitation to optimize patient status before surgery, which may help reduce post-operative complications and post-acute spending. The concept of preoperative optimization is not limited to joint replacements, it is also proving highly effective in cardiothoracic surgery. A randomized controlled trial published in the Archives of Physical Medicine and Rehabilitation by Wang and colleagues evaluated the impact of perioperative respiratory muscle training in 82 elderly patients undergoing cardiac surgery. Patients were randomized to either a perioperative respiratory muscle training program consisting of daily sessions from admission to discharge, excluding periods of mechanical ventilation, or a control group. The intervention group demonstrated significantly greater improvements in maximal inspiratory pressure, reaching 57.69 centimeters of water, compared to 48.28 in the control group, as well as superior post-operative pulmonary function and functional exercise capacity. Most notably, the training group experienced a dramatic reduction in post-operative pulmonary complications, which occurred in 38% of the intervention group compared to 65% of the controls, and a halving of the rates of inspiratory muscle weakness. Additionally, the intervention group had a shorter duration of mechanical ventilation, a shorter stay in the intensive care unit, and reduced levels of anxiety and depression. This study highlights the powerful role of simple, daily respiratory muscle exercises in mitigating the severe pulmonary risks associated with major cardiac surgeries in older adults. For patients undergoing highly complex orthopedic surgeries, such as bone tumor resections requiring reconstruction with a megaprosthesis, standardized rehabilitation protocols have historically been lacking. To address this gap, Dennison and colleagues published a study in Disability and Rehabilitation detailing the development and implementation of evidence-based physical therapy protocols for 6 different types of megaprosthesis, including hemipelvectomy, proximal and distal femur resections, total femur reconstructions, proximal tibia, and proximal humerus megaprosthesis. Developed through a rigorous consensus procedure involving orthopedic oncologic surgeons and physical therapists, and piloted in clinical practice for a year, these practical protocols outline specific rehabilitation goals, customized exercise therapies, and crucial clinical points of attention. This work provides an invaluable structured roadmap for physical therapists and physiatrists managing these rare and complex reconstructive cases, helping to standardize care and ensure safe progressive mobilization. Finally, we address a critical issue affecting our own workforce: physician burnout. While physical medicine and rehabilitation is known to have some of the highest burnout rates among medical specialties, research has historically treated the field as monolithic. In PM&R, Abdul Salam and colleagues published a narrative review investigating burnout specifically within the subspecialty of interventional physiatry, which is characterized by high procedural volumes, fluoroscopic and ultrasound-guided techniques, and the management of chronic pain. Surprisingly, the review identified 0 studies examining burnout specifically within this subspecialty. However, looking at analogous procedural specialties like interventional radiology, interventional cardiology, and interventional pain medicine, burnout rates range from 69 to over 73%, which is notably higher than the overall PM&R average of 48 to 62%. The authors propose 6 unique stressor domains for interventional physiatrists: procedural throughput pressure, the emotional burden of chronic pain management, patient satisfaction score pressure, electronic documentation burden, physical and ergonomic strain, and professional identity tension. This review serves as an important call to action for the PM&R community to conduct subspecialty specific research and develop tailored wellness interventions, rather than assuming a one-size-fits-all approach to physician well-being. If you only have time to read one paper this week, make it the cost-effectiveness study by Hayes and colleagues in the Archives of Physical Medicine and Rehabilitation. This paper provides the robust, high-quality economic and clinical evidence that physical medicine and rehabilitation physicians need to advocate for inpatient rehabilitation facility placement over skilled nursing facilities for stroke survivors, demonstrating that intensive rehabilitation is both clinically superior and cost-saving. Here are the key takeaways from this week in physical medicine and rehabilitation. First, discharge to an inpatient rehabilitation facility after a stroke is highly cost-effective and clinically superior to a skilled nursing facility, yielding significant savings and vastly superior functional recovery over 90 days. Second, when using the Berg Balance Scale to predict independent walking in stroke survivors, utilize subtype-specific cutoffs, a score of 33 for ischemic stroke and 12 for hemorrhagic stroke. Third, calcitonin gene-related peptide inhibitors may represent a valuable new tool for managing neuropathic pain in patients with spinal cord injury, potentially reducing the clinical need for gabapentinoids. Fourth, daily perioperative respiratory muscle training in elderly cardiac surgery patients significantly reduces post-operative pulmonary complications and shortens intensive care unit stays. Finally, mandatory bundled payment models for joint replacements successfully incentivize hospitals to deliver pre-operative rehabilitation, illustrating how policy changes can drive proactive, value-based care. That is your roundup for this week in physical medicine and rehabilitation. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And for audio briefings on your own clinical questions and papers, visit audioscholar.cc. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.